You are welcome to my channel. Thanks for visiting, subscribing, sharing my presentations, and leaving your comment. Today, we have a long way to go. I'll be talking about chest pain, but emphasis will be laid on heart attack. The outline will take us through the differences between heart attack and cardiac arrest, the risk factors associated with heart attack, both the modifiable and non-modifiable risk factors. What are the possible symptoms? That is what the nurses and the EMS and doctors will hear from the affected people or their relatives. What are the signs? Those will be what the EMS people, the doctors and nurses will pick upon presentation. Acute treatment, meaning what we must do quickly. Investigations, meaning the test that we can carry out. Then thorough history will be taken after. Physical examination, head to toe, particularly emphasis on cardiovascular system. After the patient has been attended to under the acute treatment in emergency room, the patient is going home, right? What else are we going to do? What are the possible complications? And of course, what will the prognosis be? And prevention, they say, is cheaper and better than cure. Now, I will quickly run through the differential diagnosis of chest pain. So, if someone is presenting with chest pain, or you are having chest pain, when it comes to heart-related issues, that is under cardiovascular system, it could be aortic dissection. It might be aortic aneurysm, and it might be the very topic for today, which is myocardial infarction or myocardial ischemia, that is heart attack. And it can be an entity that is summed together 3 in 1, that is known as acute coronary syndrome, that is ST elevated myocardial infarction, which is heart attack, non-ST elevated myocardial infarction, which is heart attack, unstable angina. It could be MVP, not most valuable player. This is mitral valve prolapse. It might be pericarditis. Still on the differential diagnosis of chest pain, and the emphasis is still on cardiovascular system. It might be aortic stenosis, might be cardiomyopathy, myocarditis, or Prinzmeter, now known as vasospastic angina. I have a full presentation on that, and you can just click on this very link to get a full presentation on vasospastic angina. It might be heart failure. The differential diagnosis will include pulmonary system, and it could be pulmonary embolism. It might be pneumothorax. We have to be careful. It might be tension pneumothorax or primary spontaneous pneumothorax. Might be tuberculosis. Of course, the history will clearly clear that. Maybe lung cancer. Might be pneumonia or asthmatic attack. Chest pain that could be pulmonary in origin might be bronchospasm or pleuritis, might be chronic obstructive pulmonary disease, could be tracheobronchitis or pulmonary hypertension. Chest pain could be a problem coming from the gastrointestinal tract. It might be gastroesophageal reflux disease, peptic ulcer disease, pancreatitis, gallbladder problems, or diffuse esophageal spasm, and it could be also vagitis. Might be a neurological problem that is giving us chest pain today as thoracic outlet syndrome, Diggs prolapse, neuropathy, or shingles. If this individual is someone that could be with sickle cell disease, then we should be careful. It might be vaso-occlusive crisis or acute chest syndrome or splenic infarct. Might be musculoskeletal, meaning is none of all these things that I mentioned earlier. Could be trauma, radiculopathy, rib fracture, osteoarthritis, rheumatoid arthritis, costochondritis, and intercostal muscle pain. It might be none of all those that I've mentioned earlier. Could be psychological, like panic attack, anxiety, and some might be self-induced by cocaine abuse or amphetamine abuse. Might be secondary to infection in the case of subdermatic abscess, and again, shingles. There are certain terms that must be defined. Heart attack. There is pain in many people. Many will not have pain. We'll go into details later on. Sweating profusely, nausea, indigestion, and so on. And you will know something is wrong. But then the heart is still working, but the heart is in trouble. Cardiac arrest, on the other hand, the heart is not pumping blood. And the person will just drop on the ground, will just fall down. So immediately, cardiopulmonary resuscitation must start here. Advanced cardiac life support must start here, from basic life support and so on. Okay, we'll get full picture in a bit. When it comes to heart attack, there's myocardial ischemia, meaning there's partial occlusion of blood supply to that part of the heart. So the tissue is still working, but sick, is not yet dead. In myocardial infarction, there's complete occlusion of blood supply to that part of the heart. The coronary artery supplying that part is completely cut off, and the region that is expected to be supplied will become dead, infarction. So that is the difference. So here on EKG, we will find myocardial ischemia to give us depression. While here it may be ST elevated or non-ST elevated. There's an entity known as acute coronary syndrome. That is made up of three friends or three members of one family. The unstable angina, non-ST elevated myocardial infarction, and ST elevated myocardial infarction. So briefly, I will just point out some few stuff about them. Here, you are not likely going to find raised cardiac enzymes when you assay that, if this is a problem. But in non-ST elevated myocardial infarction, just as in ST elevated myocardial infarctions, there will be abnormal cardiac enzymes, okay? EKG will differentiate them in the sense that ST elevated myocardial infarction, just as the name implies, the ST segment will not be elevated, while in this case, the ST segment will be elevated. Like I said earlier, that heart attack is not the same thing as cardiac arrest. Cardiac arrest means the heart is captured, the heart is restrained, the heart is not pumping any blood. And what will happen is that when any individual is having cardiac arrest, the individual will suddenly drop down because there's sudden stoppage of heart pumping ability. There'll be loss of consciousness, and it's going to affect the respiratory system at the same time. That is why it's mostly called cardiopulmonary arrest. If this happens in the hospital, the good people, the nurses, will raise alarm calling code blue. Everybody will come around, doctors, nurses, trying to help the affected individual. If it happens in the mall, at home, anywhere, those that are trained in advanced cardiac life support processes and basic life support programs will be able to use the skill to rescue the affected person. So, from myocardial ischemia, that is partial occlusion of blood supply to the heart muscle, leading to possible complete occlusion and subsequent tissue death called myocardial infarction, then the process to cardiac arrest could be setting in. Another condition is called long QT syndrome, which could progress to todavica point, from todavica point to ventricular tachycardia, from ventricular tachycardia to ventricular fibrillation, and from ventricular fibrillation to asystole. So if the heart is in trouble, having myocardial infarction and left ventricular function is impaired, and with the help of echo, the left ventricular ejection fraction is low, there is a way to help such people by implanting cardioverter defibrillator. But if that is not done and the individual goes into ventricular fibrillation, there is possibility of sudden cardiac death or cardiac arrest. The commonest cause of cardiac arrest or sudden cardiac death is ventricular fibrillation. Okay, modifiable risk factors. Generally, the risk factors are divided or categorized into two. Modifiable meaning we can do something about it, we can correct it, we can adjust it. While the non-modifiable that we will touch in a bit, we can do nothing about that. Smoking. Smoking alone is the strongest modifiable risk factor that will give us heart attack. There are a lot of nicotine replacement therapy agents out there. In fact, I have a separate presentation on smoking cessation already published here. I think I have two of them. You can check my channel for that. Heavy alcohol. I use the word heavy because there's a small level of alcohol that could be, tolerable. But then if you can stop alcohol altogether, that might be helpful. And some will actually campaign for some level of alcohol that it is beneficial. Well, either way, heavy alcohol would destroy the heart the more and lead to heart attack. Then high level of low density lipoprotein is bad for us. We don't need that. And when we need the high density lipoprotein but we're not getting and we have low high density lipoprotein, please let me explain this very well. Low density lipoprotein is what we don't want, is the bad cholesterol. When that is very high, then we are running into heart attack. We need the high density lipoprotein, that is the good cholesterol. When it is low, then we are in trouble. Sedentary lifestyle or inactivity, you know that I don't need to swear over that. Just get out of the couch, walk around, jog, play soccer, stress yourself out, walk your dog or your cat or anything. Stress, anger, fear can all lead to even acute attack of heart attack. Okay, I'll go into that in a bit, so I won't waste your time here. Obesity. The bigger we are, the closer we are likely going to be to the grave through heart attack. Diabetes mellitus without treatment, I specifically put this here that without treatment. The reason is if you have diabetes mellitus, it's not death sentence anymore. It was in the past, but thanks to the good medication right now from insulin to all other agents, if diabetes is well controlled, you may not come down with macrovascular complication, one of which is coronary artery disease that will lead to heart attack. So compliance with instructions by dietitian, by your endocrinologist, your family physician will not lead you to heart attack. Hypertension, whether essential or secondary. Secondary means there's something responsible, particularly in younger age group. If either essential or secondary, once it is diagnosed and you are following the instructions, you are taking the medications at the regular time and correct dosage, and your BP is under control, well, you have the risk, but then it's getting reduced. Obstructive sleep apnea is a big problem. And I have a separate presentation on obstructive sleep apnea and central sleep apnea. I'll go into that in a bit. So anyone with obstructive sleep apnea should be very careful. That's a modifiable risk factor for heart attack. I have two links here, one for obstructive sleep apnea. So if you click on this, you get to obstructive sleep apnea, already published by me. And then the central sleep apnea is right here. So if you click on this very link, you will get full info on central sleep apnea, already published by me. Now, the non-modifiable risk factors, meaning we cannot adjust it, we cannot change it, we can make it better. It is non-modifiable. We cannot modify it. Age. The older you become, the higher the chances. But gone are the days when we assume that people, unless they reach age of 50 and above, they cannot have heart attack. People are having heart attack at 30 right now. So depends on certain medications you are taking and certain comorbidities in you, and of course genetic predisposition. Like a female with positive family history in the mom or the dad or the first degree relative, and she's down with maybe diabetes mellitus, and on top of that, she's taking combined oral contraceptives, and she's obese, and then not exercising. She might be so young that she will come down with heart attack. Family history. The probability increases if it is a first degree relative. For example, if your first degree relative is a male, and he came down with heart attack at about 55, and the female first degree relative has come down with heart attack at about 60 or younger, then you better check it out right now before you reach 50. If the male is 55, check it out from 40. If the female is 60, better start checking it now once you are 40 and above. Gender. This is very common in males, but it increases also in postmenopausal women. So postmenopausal women and male are almost equal, but premenopausal women will have less tendency to come down with heart attack if other factors are not present. Okay, the race. We are all in this. It is a worldwide problem. And some will say hypertension is commoner among blacks, but coronary artery disease is commoner among whites. They are not wrong, but if you look at the epidemiology worldwide right now, no race is left out anymore. Okay, so it depends on certain other comorbidities and family history and so on. Still on family history, if you think, oh, my dad had heart attack, so I'm now 50 and I'm worried. The first question I'm going to ask is, at what age was your father diagnosed with heart attack? If your answer is, oh, he was 85 or 90 or 100, I will not bother about that today. Okay? If your first degree relative is pretty old before coming down with heart attack, then the positive family history is not the very, very strong factor anymore if other risk factors are not found in you. I think I made myself clear, right? So if the first degree relative is a male and is down with heart attack at 55, that is a very, very strong family history risk factor. But if he became diagnosed with heart attack, or no, he died at 89 of heart attack, that is not what I'll be running around to check out in you right now. I'd rather look for other risk factors in you today. Triggers of acute attack, meaning those things that could lead you to heart attack suddenly. Okay? Fear. Remember, when you are fearful, you have what is known as 3 Fs: fright, flight, or fight. Adrenaline is released in the blood. Sweating, everything. You can have heart attack. Anger, yeah, or rage. Oh, everything is up there. Be careful, you may have heart attack. Exhaustion, or sometimes could be at rest. Okay? Weather, particularly in temperate parts of the world, cold temperature. This explains why some elderly men and women will collapse while shoveling snow in winter. Yeah, cold weather. Street drugs. Oh, you're not helping yourself with the cocaine or the amphetamines or with the fentanyl and everything that is adulterated. Why don't you stop it and have a longer life? Street drugs can trigger heart attack. Cocaine in particular will give you chest pain, can give cardiac ischemia. There's a separate presentation on don't use beta blockers in cocaine-induced chest pain. You can look for that on my channel here. Low oxygen supply, of course, either low oxygen supply or high oxygen demand to the heart. We make the heart attack to be worse if at all it's present. So those are triggers of heart attack. What are the symptoms of heart attack? This one will lead me to two areas. Some will be typical and some will be atypical. So right now, I'll go through the typical presentation. Someone could present with pressure or fullness in the chest, could be just nausea. And classically, some will present with chest pain. The pain will be radiating from the chest to the arm, to the neck, to the jaw, and to the abdomen. Okay? But it is not in everybody that we're going to pick that. Could be nausea alone in some, or pressure or fullness. Some will complain that they have back pain, tingling, epigastric discomfort, shortness of breath, lightheadedness, or dizziness. Some will present with some of these. Okay. Then still on symptoms, some will present with the story that I have squeezing in my chest, I feel some aching, and then I become fatigued, have heartburn or have indigestion, while some will tell us, oh, they have abdominal pain. The signs are what the nurses, EMS people, and doctors will pick. Diaphoresis. The individual may be sweating profusely. Levine sign, they make a fist and place it on the chest to describe what is going on inside the chest, because at that time, they may not be the type that will be able to talk so much. Dyspnea, that is breathing problem. Autopnea, they cannot lie flat without breathing problem. They can be coughing because of pulmonary edema. And then you can see edema around the eyes, the eyelids, periorbital, or down at the feet as a peritibial edema. Then you can see that the individual becomes restless or in obvious distress or anxiety. They are afraid. Am I going to die? Would this doctor be able to help me? And paucity of words. This is not somebody who will be singing and talking and talking and talking. Just few words will be coming from them because they are in distress. Wheezing. When we place the stethoscope, we can pick wheezing if there is pulmonary edema. Atypical heart attack or atypical myocardial infarction or silent heart attack. I have a separate presentation on this also. You can check my channel for that. Here, the signs and symptoms described just before now may not be present. Okay? That's why it is referred to as atypical or silent. But that has not ruled out the heart attack. So the heart attack is still ongoing. This is very common in females. Okay? It's common in females. Whether mostly here there will be no pain that is associated. If at all there is pain, it could be back pain only, and if care is not taken, you just give painkiller and she's going home and then she's dead. It might be just mild with squeezing or just tightening of the chest. Here I'm going to give one true life story of a female, a registered nurse. I will not name the hospital because some people will know her right there. So to let you know, it's not that because you don't know what you are doing, it is just atypical, it's just silent. This hardworking, smart lady presented at the emergency room of the same big hospital that I'm just feeling somehow, I cannot even say, but I'm just feeling that I'm not myself, just a little squeezing in my chest, and the doctor auscultated, did everything, just said, okay, don't worry, I don't think it's anything much. Okay, cardiac enzymes were not acid, EKG not run, and she went home. She was at home, she had the future ahead of her, she went online, typed everything, and then she had a plan, everything on Facebook, on Instagram. Then she slept. She didn't wake up. She passed on. That is to let you know, this is a registered nurse, right? She knew what she was doing. She was brilliant, she was smart, but then died of silent heart attack. The other group, apart from females, will be anyone with diabetes mellitus. The other group of people that can have silent heart attack will be elderly people. And also the fourth group will be someone who had undergone coronary artery bypass graft or cardiac transplant in the past. When that, some nerve would have been severed, okay? So they won't feel the pain. Like pain is not fact, neuropathy in DM, right? And of course, some patients will have high threshold for pain. I remember my OBGYN days as an intern. I was counseling, a young woman, a primary-parous woman, that when you are in labor, you don't have to be yelling and yelling on top of your voice because she was about, she was already down that time. So I just joked about that, and lo and behold, when she was in labor, she didn't yell. And then by the time they knew that the baby was around, the head was already at the perine. And then one of the midwives said, "Why did we didn't even see you yelling?" And then she mentioned my name, that advised her not to be making no noise, that the noise won't resolve the problem. Okay, so that's just a digression, that some really have high pain threshold. They don't feel pain quickly. Neuropathy or denervation, just as I've said, surgery or DM or just neuropathy of any sort. Also, the silent class of people that could have silent heart attack will be people with high beta endorphins and anti-inflammatory cytokines. And the eighth group is we have to be suspicious if in this individual the past history of coronary artery disease, or there's none, but with other risk factors, we should be suspicious and then just do something. Just have cardiac enzymes, have EKG done, and then if you then need to do more, you will know after. When it comes to the silent heart attack or atypical heart attack, do we really need to make the diagnosis, or how can we make the diagnosis of that? Okay, let's go through this. We can have screening with stress test done. Some centers may use ambulatory monitoring, and we can use EKG with echo, with myocardial perfusion imaging and troponin. Then, what are we going to do? We'll take history and physical examination. Then those who need screening the most will be competitive athletes, pilots, sailors, drivers. Why that? There are a lot of people under their watch. So if they have heart attack, any heart attack that will kill them will kill many people. So this is what we can do. Okay, EKG with echo, myocardial perfusion, imaging, and troponin. And of course, we take thorough history and physical examination, like a competitive athlete. Any history of sudden death in your family, many of them will be hale and hearty, running, playing soccer or football, falls down on the pitch and dies suddenly. So that will give us a clue that now we need to have screening done for this person. And of course, apart from the athletes, pilots, sailors, drivers, how about the willing patients? Some will be willing, but it depends on your jurisdiction. If the financial support is not right there, that might be a problem. And of course, we should use our high index of suspicion. Now, treatment and diagnosis. When we were in medical school, we memorized this B-MONA, that is beta blockers, enoxaparin, morphine, oxygen, nitroglycerin, and aspirin. That's what we use. But we now know that it's not going to go just like that. We can't just memorize this and say, oh, I'm going to give all this. So it's not going to go just like that. But we should get ourselves equipped with aspirin, with oxygen, and nasal spray, IV fluid, an IV fluid giving set, antiplatelets, low molecular weight heparin, morphine, nitroglycerin, beta blockers, angiotensin converting enzyme beta, statins, thrombolytic agents. Consult should be ready to go to, cath lab for PCI and stenting. Surgeons for coronary artery bypass graft, vital signs machine or cardiac monitor, and Foley's catheter. Get ourselves equipped with all these. Okay, we need to act fast. With that, the more time we waste, the less the probability of survival. We must open the blood vessels fast. That is why PCI and stenting is the first thing to ask for. And if that is not available, then clot busters or thrombolytic agents. Okay, the patient is right here. Swelling profusely. Brief history will be taken. Then we'll go for the airway. Clear the airway. Any secretion, foreign body, suction, remove as appropriate. What's happening to the breathing? Any central cyanosis, peripheral cyanosis, chest moving with respiration and abdomen, any obvious deformity, tracheal deviation or not. What's the respiratory rate? Auscultate for wheezing, breath sounds. And then what is the O2 sat? If it's low, we give oxygen, nasal sprung right now. Circulatory system, what's going on? Any dehydration, capillary refill, blood pressure, heart rate, then we'll give our fluid, put it up, set IV lines, and then go for vital signs, blood pressure, respiratory rate, heart rate, and temperature. And then cardiac monitor must be up. Pulse oximetry, you want to know what is happening to the O2 sat. Greet this patient with aspirin, 325 milligram, non-enteric coated to be chewed. Okay. The IV flip, we have to be very careful depending on the diagnosis. If it is inferior wall myocardial infarction, I'll go into that later. That is lead 2, lead 3, and AVF. Then we need to give generous fluid. Okay. But if it is just for maintenance, we can give 0.45% saline plus D5 water at 100 cc per hour. Order EKG now. We'll order the EKG and repeat the EKG because EKG is prone to change. And EKG may not even give us future right now, but just one EKG is not enough. Order EKG now, repeat EKG after. We will give oxygen if O2 sat is less than 92% at 4 liters per minute per nasal sprung. Nitroglycerin will be given, but we will be very, very careful. We want to know if we are dealing with inferior wall or not. That is why EKG will come before I give my nitroglycerin. Okay? Then I would have known the BP and the heart rate before I give my nitroglycerin, because if the BP is low, like anything lower than 90/60, no nitroglycerin right now. And if it is inferior wall from EKG, no nitroglycerin right now. But if all those things are ruled out and history of nitrate intake is also ruled out in this person, particularly if this is a male and who would have taken Viagra for, you understand why, we will not give nitroglycerin right now, okay? So if we rule all those things out, we can give nitroglycerin 0.4 milligrams sublingual. Also, before giving our aspirin, though it is a routine, I will welcome the patient with aspirin. How about any hypersensitivity to aspirin? Or the individual is bleeding somewhere, we will not give it at that situation. Also, morphine. It's good. We want to relieve the pain. We want to give the analgesic. Morphine 2.5 milligrams intravenously is fine. But what is the BP telling us? Okay? And is this inferior wall or not? Best thing to then do is, please, nurse, can you help me? Place the call to cath lab right now for PCI or PCA. Either is I or A, it doesn't matter. Percutaneous coronary intervention or percutaneous coronary angioplasty is all the same. Okay. This should be done within 90 minutes at the emergency room, or at least within 12 hours of symptoms. We must get this across to them. But if we don't have that in my center, the journey has not ended. We'll still do more. Okay, we will call the lab people. They will draw blood for investigations. What do I need to get done? Cardiac enzymes, troponin, CKMB. I will delve more into troponin in a bit. Have glucose level, complete blood count, INR and APTT. Why that? I may have to give thrombolytic agents. Renal function, electrolytes, potassium, calcium, magnesium, sodium, lipids, and thyroid function test. I'll get them done. Okay, like I promised, that I will delve more into troponins. Let's go. Rise and fall of troponin can only be found in cardiac muscle in infarction, not in other places. That is, let me explain this. Troponin level can rise and fall. And if that is the case, it means you are dealing with a problem that's limited to the cardiac muscle, particularly infarction. Why that? In chronic kidney disease, troponin may rise, but we will not have a rise and fall phases like we will find in cardiac muscle damage. I think you are getting it now. Troponins will rise in cardiac muscle problem, in musculoskeletal problem, in chronic kidney disease, but it is only in cardiac infarction, in heart attack, that it will rise and fall. In chronic kidney disease, it will rise, but we will not see rise and fall phases. Hence, there will be a steady state in chronic kidney disease. Biotin effects on troponin. You can check my channel here, click on this very link to take you to a full presentation on biotin effects on troponin and thyroid function test. You may assay for biotin, and you can take history of biotin containing vitamins intake before you do your troponin if that is the case. However, we need to know that biotin can give us false low level of troponin, meaning the troponin is actually high, but because with the presence of biotin in the multivitamins the individual had taken, the lab will report that the troponin level is low. And what will happen? We will miss the diagnosis of heart attack and the patient may die. Biotin could be found in multivitamins, B complex, coenzyme R, prenatal vitamins, also in vitamin B supplements or vitamin H. Dietary supplements for hair, skin, and nail growth could contain biotin as well. Troponins. Serial troponin assay is necessary. Please follow the protocol in your center or institution or call your cardiologist. You have to do that at presentation, then 3 hours later, or 3 to 6 hours after symptom onset. If the initial result is that troponin is negative, then repeat troponin test in 3 hours and another in the following 6 hours. There is a strategy known as 0-3-hour rapid rule-out strategies. And in that case, you are going to use high sensitivity cardiac troponin I. Still on troponins, in ST elevated myocardial infarction, that means there's ST elevation with the rise in troponin I. In non-ST elevated myocardial infarction, there is no ST elevation, but there's a rise in troponin I. Troponin I has a high specificity for cardiac muscle, also has 100% sensitivity. So some of us will just call for troponin I. Though you may not want to be ambiguous by just writing in down troponin I, but we should know also that troponin T is in a very high concentration in cardiac muscle. But troponin I is exclusively to the heart. Troponin T is also found in skeletal muscle. You may say only troponin I, but troponin T is also good. For differential diagnosis of high troponins, please check the link below. I have that fully published right here. Okay, back to the acute treatment. Now that we've learned everything about troponin, we can have echo down. Transesophageal echo will be what I'll call for if I have the physician that will be able to do that right away. Transthoracic echo will help, but not as much as transesophageal echo. Coronary angiogram, cardiac CT. As a matter of fact, there's a full presentation on echo right here. Magnetic resonance imaging, and then you can have positron emission tomography, and then single photon emission computed tomography. Okay, so you can have all this done. Okay, we need to repeat EKG and do chest X-ray. Is the result of the EKG out? Yes, of course. Okay, and what is it all about? Oh, we have non-ST elevated myocardial infarction or unstable angina. Oh, meaning no ST elevation, no bundle branch blockage, no pathological Q wave. Oh, great. Then we will not give thrombolytic agents here. So in non-ST elevated myocardial infarction and unstable angina, no thrombolytic agent. But we will do something. We will take the score of thrombolysis in myocardial infarction, and we can give low molecular weight heparin and angiography if the result or the score of thrombolysis in myocardial infarction is greater than 3. If it is 0 or 1, we will not give this because it means the percentage or the risk of dying is pretty low. Okay. Timing is useful in determining the degree of severity or risk of dying in non-ST myocardial infarction or unstable angina. And we have 7 factors to go through. Each will be a score of 1. So anyone with 0 or 1 will have very low percentage probability of dying. So greater than 65 years old, 3 factors or more for coronary artery disease like hypertension, diabetes mellitus, smoking, positive family history, and so on. Coronary artery stenosis greater than 50%. Have you used aspirin in the last 7 days or 1 week? ST deviation or changes greater than 0.5 millimeters. When cardiac enzymes were acid, were they raised? Is it less than 24 hours that the patient is presenting? So we'll go through this. When it is greater than 3, we'll have angiography and low molecular weight heparin, but no thrombolytic agent. Okay, EKG is there, and it is ST elevated myocardial infarction. Oh, also new bundle branch block has been seen. Pathological Q wave is present. Please cath lab. For what? For PCI or PCA. I don't care whether you call it I or A. Cath lab right now. But Oh, bad news. The doctor is not available or my center cannot have PCI done. Then I have to go through contraindications to thrombolytic agents in these patients. I must rule them out fast. Once they have been ruled out, then with the help of the cardiologist, we will start our recombinant tissue plasminogen activator, a thrombolytic agent. Okay, the contraindications to thrombolytic agents are intracranial hemorrhage, ischemic stroke in the last 3 months, brain tumor, head injury, aortic dissection, arterial puncture recently, major surgery within the last 3 weeks, currently on anticoagulants. If none of this is present, oh, great. We can go ahead with the help of the cardiologist, if you are not one, to give recombinant tissue plasminogen activator or TNK or streptokinase. Streptokinase has fallen out of favor because it is known that when you give streptokinase for the first time, there is likelihood of immunity being developed against it. So when you give it the second time, it's like you are giving nothing. That is why people say you give streptokinase only once. So many people will go for recombinant tissue plasminogen activator. Okay, the EKG that's showing ST elevated myocardial infarction will give us clue on certain stuff. If the elevation is at least 2, 3, and AVF, then we are dealing with inferior wall myocardial infarction. If that is the case, it is likely that we will have a better outcome. Here is mostly due to right ventricular infarction, and we'll be battling with hypotension, bradycardia commonly, and then the artery that is likely involved in many parts, of the world and majority of the people will be right coronary artery. So, if our diagnosis is inferior wall myocardial infarction based on list 2, 3, and AVF, SC elevation, then we must be careful with beta blockers, be careful with nitroglycerin and morphine. As a matter of fact, we'll keep them off for now, and we'll rather go for IV fluid generously for now because we're dealing with hypotension. And because of bradycardia, you don't want to give your beta blocker again. In the face of hypotension, why will you give nitroglycerin and morphine? Okay? But if it's in list V1 to V6, limb lead 1, and AVL, then we're dealing with anterolateral wall myocardial infarction. That is bad. That has the worst prognosis or the worst outcome. Why that? A larger area is infarcted already, and the tendency to rupture is pretty high. This part, this larger area, is going to be supplied by left anterior descending artery or left middle circumflex artery. But if it's at V1 to V2, that means it's affecting the septum. Here I have now a small sketch of electrical activities starting with P, Q, R, S, then the T. But here should be the J point. Let me mark that. Okay, the J point should be here. And then this is the beginning of the T. So we are concerned about what is happening here. That is ST segment is right here. Now the ST segment. The KRS is representing ventricular depolarization. The T wave is pointing to ventricular repolarization. In between them is the ST segment. That is the region between the two above. The J point is the meeting point of ventricular depolarization and repolarization, like I've alluded to, and we will see in a bit again. Normally, the ST segment is isoelectric, meaning there's no voltage gradient at that level. If the ST is not isoelectric, then something is wrong with the myocardium. Okay, we've gone through the hand sketch, showing the different waves, but now I really want to get down to ST segment and point at elevation and depression. So this is the J point. Okay, you can see the J, right? Okay, and this is the beginning of the T, and this is the ST segment right there. You see that it is isoelectric, it's flat. That's what we expect under normal situation. Then the second diagram is then pointing to elevation of that. You see, this is the isoelectric point, but here there's a distance, it's elevated. So elevated ST segment. The third diagram is showing it more clearly. Okay, then if you now check down here, A, B, C, something different is happening here. You see that this is the isoelectric line, should be like this, but instead of elevation, it's down. You see that it's down here, like this, okay? And then here, when you look at this again, it's also down. So it's down here, okay? It's down. And here, same thing is happening, it's down. So this is depression. This is depression. Unlike this, that is elevated. See, if you go from here, is elevated. Okay, elevation from here like this, it's elevation. Okay. STEMI shapes of elevation. When it is STEMI, it is converse. Okay, in left ventricular hypertrophy that is uncomplicated, it is concave. In early repolarization, is going to be greater in lead 2 than lead 3. In inferior wall MI, is going to be greater in lead 3 than lead 2, meaning the degree of elevation will be greater in 3 than 2 limb leads in inferior wall. Depression, on the other hand, is that ST segment is going to be depressed in myocardial ischemia, in certain medications, in hypokalemia, and in exercise. In inferior wall myocardial infarction, here the problem will be with right ventricular myocardial infarction. We will likely have the presentation that will be involving diarrhea, hypotension, and bradycardia. Diarrhea in the sense that the artery is lying posteriorly, so ischemia there can lead to irritation of the gut and leading to diarrhea. So hypotension and bradycardia will be expected to give IV fluid generously. We will not be expected to use our nitrates or nitroglycerin, and will be expected not to use beta blockers. Okay, when we see ST elevation, it doesn't mean we are dealing with heart attack alone. ST elevation could occur under many conditions, and we'll go through them right now. Could be normal variant in young black men. It could be in myocardial infarction that we are all expecting to be, right? It could be in left ventricular hypertrophy, right bundle branch block, left bundle branch block, or acute pericarditis. In this case, it will be diffuse. The ST elevation will be found in many leads. When the ST elevation is all about myocardial infarction, it might be inferior wall. In that case, the elevation will be at limb leads 2 and 3, and of course AVF. It might be in the septal region, and that will be chest leads V1 and V2, anterior chest leads V2 to V5, anterolateral V1 to V6, limb lead 1 and AVL. The lateral will be limb leads 1, AVL V5, V6, anteroseptal V1 to V4, posterior will be V7, V8, and V9. And right ventricular infarction will be more glaring with V3R, V4R, V5R, and V6R. ST elevation could also be depicting pulmonary embolism, hypothermia, Brugada syndrome, raised intracranial pressure, presmental angina, or vasospastic angina. Might be as a result of hyperkalemia, dizzy transthoracic cardiovascular, subarachnoid hemorrhage, stroke, left ventricular aneurysm. Might be as a result of hiatal hernia, acute pancreatitis, myocarditis, pneumothorax, ventricular paced rhythms. Also, the list of differential diagnosis of ST elevation will include least mispositioning. So we must be very careful while interpreting this. That's why cardiologists will be the best person to help out. Atelectasis, aortic dissection, medication like clozapine, pulmonary metastasis. It could be tachytubal cardiomyopathy, acute cholecystitis, or early repolarization. ST elevation with Q in the precordial leads V1 to V6 with or without limb lead 1 and AVL is representing high lateral leads. There will be reciprocal ST depression in inferior leads, that is leads 2, 3, and AVF, if the high lateral leads will have ST elevation with Q in the precordial leads V1 to V6 with or without limb lead 1 and AVL. The differential diagnosis of ST elevation, full info is right here. You can click on this very link to get that done. I mean, if you want no more info on possible differential diagnosis of ST elevation, the full presentation is right here. Please click on this very link. Okay, we are not done with acute treatment yet because the patient is not yet discharged. So anticoagulants like low molecular weight heparin at 1 milligram per kilogram could be given subcutaneously, but we need to know the value of INR and APTT before then. We may give antiplatelets, and now I will be comfortable with ticagrelor at 180 milligram start with aspirin. Beta blockers like metoprolol 25 milligram per oral could be given, but we can use diltiazem if beta blockers are contraindicated. For example, if this patient is asthmatic or sick sinus syndrome. then we can give statins, or we insert a Foley catheter and monitor for fluid input and output. Please contact the cardiologist from the onset. Contact the family so that it will not be like battery, because this person may not be able to give consent. You need someone to give consent for everything, including thrombolytic agents used, and also PCI and so on. Take full history now, full physical examination, and plan for post myocardial infarction management. Now, full history. We need to know the onset of this pain or pressure or feeling or indigestion or whatever the presenting symptom or symptoms will be. The cause and of course duration. Is it getting worse and for how long? History of this very present illness in details. Sweating, any chest pain, and if the pain is present, the QRS characteristics of the pain. Then the nausea, dyspnea, any shortness of breath. When you lay down, do you find it difficult to breathe? That is autopnea, and you need to get up. Paroxysmal notional dyspnea, of course, I think there will be a time that will have a different name, because you can lay down during the day and then have dyspnea, but paroxysmal notional means at night. Are you coughing? If you have the color of the sputum, any heart raising, that is pointing to arrhythmia. How about loss of consciousness? Have you fainted? No. Facial or pedal swelling, any headache, any blurred vision, and claudication, that is, you feel pain at your calf when you walk. And then how many blocks you walk before you feel the pain, and is it worse during the cold time, winter time, and so on. Now we'll go into the past medical history in this very patient. History of hospitalization. Have you been admitted in the hospital for heart attack in the past? Have you ever been diagnosed with hypertension? And if you have, any treatment? And are you, taking the medications appropriately and the lifestyle changes? Are you complying with that? Diabetes mellitus. When were you diagnosed? Are you on treatment? This will give us clue to if we are dealing with coronary artery disease right now due to diabetes mellitus or not. Thyroid disease, particularly hyperthyroidism in this case. High cholesterol level. When last were you checked? Particularly the level of low density lipoprotein. That would be bad if that value is high. And we want to know the level of high density lipoprotein. That would be bad if the value of HDL is low. Allergy, we want to know about what you're allergic to because of the medication will be given right now. For example, the individual could be allergic to aspirin, and then you need to give aspirin that he or she will have to chew right now. Past surgery. Maybe the past surgery is responsible for the silent heart attack we have right now, like coronary artery bypass graft, and diabetes could also be responsible for that as well. Are you on any prescribed or over-the-counter medication that could affect all other medications that will be placed upon right now and that we can send you home with? Now, family history. Are your parents alive? Please don't feel offended if this question is posed at you, because some will feel that I'm the one sick while asking about my father and mother and great-grandfather and my siblings. Oh, we need that, please. Are your parents alive? If they are dead, what is responsible? You know the cause of death. If it is as a result of heart attack, at what age? If your dad died at 50, 55, then there's a problem right now. But if your dad died at 80, 90, 100, I worry less about family history due to that. Or your mom died at 60 because of heart attack, then there's a problem right now. If parents are dead, we need to know the cause of death and at old age. Coronary artery disease in the family, hypertension, diabetes mellitus, thyroid disease in your family. Sudden cardiac death in the family, if that is the case, we might have the reason right now to be forced to do certain investigations like echo and so on. Social history. Are you smoking? Remember the modifiable risk factors? They are right here. Now, nicotine replacement therapy is out. There are certain presentations already published by me on smoking cessation. You can check my channel for that. So stop smoking. That's what I'm going to tell you, okay? Alcohol. Well, I don't take alcohol, but I would advise if at all you do, the barest minimum. Drugs. Quit. No more cocaine, no more amphetamine, no more fentanyl. All these will kill you. Diet. Balanced diet. Good one. No. Uh, dash diet. Okay. Uh, Not junks. And of course, I will refer you to dietitian. Okay. Exercise. Are you exercising? At least walking your dog, jogging, swimming, dancing could help. Stress. You're a businessman crossing 2 continents in 2 days. You have to reduce the stress if you're having heart attack right now. Remember, heart attack can reoccur, okay? Review of system. Now, the central nervous system, the gastrointestinal, the respiratory, everywhere we'll ask questions as might be necessary, and of course, full physical examination. Post myocardial infarction treatment. Okay, congratulations on the successful initial treatment. Ooh, great. The patient is fine, smiling right now. The spouse is around, the kids they are around, the friends are around, everybody is happy. Okay. We are not done yet. And someone is asking me, what else do you have to do? We have more to do for this grandpa or grandma. Okay. Upon discharge, we will sit the patient down and have some words of counseling. Stop smoking, please. If that has been picked during the history, decrease your alcohol and it will be better to stop it. But there are a lot of literature reviews over saying alcohol is good at some point for the heart and so on. Well, decrease your alcohol to the barest minimum. Increase exercise. But we have to do stress test before then to determine the level of tolerance. I mean, what you could tolerate, as per the exercise. Follow up compliance or adherence to whatever instruction your family physician will give you later on as per lifestyle changes and medication. Share that weight. Decrease your weight, please. Good diet. We'll send you to a dietitian and give you pamphlets on that. Decrease the stress in your life. Please appoint somebody to do the job for you. Some CEOs, after sometimes because they don't want to die young, they want to enjoy the money they've made, will quit and let someone else take on the baton. Treat hypertension. If you've been diagnosed with hypertension, treat your diabetes mellitus if you have been diagnosed with one, because if you don't treat diabetes mellitus, in fact, in the olden days, the grandfathers in medical school learned that once you know diabetes mellitus, you have known internal medicine because it's going to affect all parts of the body. Now, coronary artery disease is one of the macrovascular complications of diabetes mellitus. So you'll be helping yourself if you are complying with every instructions, including medications, as per diabetes mellitus treatment. If you treat your diabetes mellitus pretty well, you may not come down with all these troubles and die, natural death or something else will kill you. Okay, remember we are now at post-initial management. So if percutaneous intervention had been done in cath lab before, because you have ST elevated myocardial infarction, then we'll follow this algorithm. We will do EKG now and echo. We want to know the value of left ejection fraction. If it is less than 35%, there must be installation of implantable cardioverter defibrillator. If there is arrhythmia like atrial fibrillation, we will use D-Tazan or beta blockers in you. We'll place you on warfarin, antiplatelets, ASA with clopidogrel or with ticagrelor. We will repeat lab results and cardiac enzymes, troponins, okay? And we will give statins. You can give beta blocker like metoprolol, particularly if you have AFib, and even if you don't have AFib, we'll give low dose of metoprolol. ACE inhibitor will be great, particularly in patients with diabetes mellitus. As a rule of thumb right now, people with diabetes mellitus are placed on ramipril, low dose, if they don't have high blood pressure. But we have to watch the blood pressure pretty well. But if they have high blood pressure, then we'll increase the dose. ACE inhibitor is pretty good for diabetes mellitus patient for cardiorenal protection. We'll continue nitrogen PRN for discomfort and for pain. We'll correct conditions like all modifiable factors, the lifestyle changes, right? So reduce the weight, remove the stress. We give anxiolytic if you're anxious, like selective serotonin reuptake inhibitors for depression if you're depressed. Exercise stress test with EKG and echo to determine the level of exertion that I will suggest. Okay, the patient is done, fine, about to go, but you remember this patient had non-ST elevated myocardial infarction and never given PCI, or he or she had ST elevated myocardial infarction, you gave thrombolytis, but thrombolytis had failed. So the next thing now is to consider rescue PCI in anyone with ST elevated myocardial infarction who had received thrombolytic agent, but there's no full reperfusion yet, meaning failed thrombolytic agent. Then we'll call for rescue PCI in STEM. On the other way, anyway, we will consider PCI for the first time in non-ST elevated myocardial infarction or unstable angina because they couldn't receive thrombolytic agents, okay? But they are now having recurrent chest pain, then PCI. The left ventricular dysfunction is showing that left ventricular ejection fraction is less than 35%, then have PCI. They are now having hypotension, let them have PCI. The exercise stress test reveals that they have high risk, let them have PCI now. Now, complications of myocardial infarction. Reoccurrence, it can reoccur. They found that heart attack has occurred, you've been to the best hospital around with the best doctor and best nurses, doesn't mean it will not happen again. It can reoccur, okay? That may be shock or congestive heart failure within 2 days of the diagnosis of myocardial infarction. Papillary muscle may rupture, and maybe septal defect. There might be tachycardia or bradycardia. There might be post-infarct angina. The individual can develop DVT and thrombus. Pericarditis can occur, and of course, Dressler syndrome might be the case in 2 to 8 weeks. Prognosis. ST elevated myocardial infarction mortality is high, between 5 to 10% in hospitals, while non-ST elevated myocardial infarction mortality is lower compared to ST elevated myocardial infarction, the end stemming will be between 2 to 5% in hospital. Recurrent MI is possible, like we just said. Heart failure, arrhythmias, angina, stroke, and death. So someone with heart attack can be dead, can have recurrent heart attack, can have heart failure, can have arrhythmia or palpitation, a developed angina, can come down with stroke, and of course death again. Prevention. Prevention, they say, is cheaper than cure. That is, if the situation is curable at all. Prevention is better. So please go over the modifiable risk factors and go the opposite direction. So if you are smoking, stop smoking. Heavy alcohol, PRS minimum. Big body mass, reduce the weight. Sedentary lifestyle, become active. If you want me to take each of the modifiable risk factors in details, you can let me know. Wishing you and myself a sound heart, or sound palm, and healthy life. So in conclusion, heart attack can be attacked at emergency room, meaning the doctors and nurses can attack the heart attack. No, they can stop it if you present on time. Prevention, however, will be cheaper than that cure here. Will be better than waiting till when you have the attack and getting to the emergency room and the doctors helping you. Know your family history and check the other risk factors. Remove heart attack by changing your lifestyle for better. With that, I've come to the end of this long and lengthy presentation, but I hope that this will be helpful to many people in many parts of the world. Thanks. Remember to share this. Remember to subscribe to my channel. And you're free to leave your comment. I appreciate it.